today, Dr. Rugo.
Okay, great. I think I can start now. Yes? Thank you so much, Mafalda and Sonia, for inviting me. And I think it's been such a challenge in the current time, and we're all, I think, trying to manage in the best possible way, and being able to continue these educational events by virtually is, I think, really such a challenge. And I congratulate you and your organizers on being able to create such a polished and excellent meeting. And it was really great to hear that last talk as well. I feel like we're all missing that interpersonal interaction, and this meeting allows that, which is really wonderful. So thank you very much for inviting me to participate. So my topic is defining the optimal, oops, I'm going back and forth, sorry. Defining the optimal treatment sequence and role of biomarkers in luminal metastatic breast cancer. This is, of course, a huge challenge. We heard about the heterogeneity of triple-negative breast cancer in the last talk. If anything, luminal breast cancer is even more heterogeneous. Based on we really have defined luminal breast cancer as the presence or absence of hormone receptors, but we know that it's much more complicated than that. We can see here data regarding subtypes in hormone receptor positive breast cancer from a very nice study published in 2018, looking at different intrinsic subtypes by gene expression profiling in patients who have hormone receptor positive disease. What you can see is that the dark blue, or luminal A, comprises the majority of these cancers in general. And you're looking here, just to tell you, here's advanced breast cancer here, here's the global cohort, and then HER2 negative and HER2 positive. So if we don't look at the HER2 positive group now, since we're talking about HER2, we're talking about HER2 negative disease here in this presentation, and we look at the difference between early breast cancer and late breast cancer. First, keep in mind that this isn't a completely accurate representation of advanced disease, because this included some patients who had metastatic disease but submitted early breast cancer samples. But what you can see is that there's relatively less luminal A disease in the metastatic setting. And this has been shown by other investigators as well. And what you can see actually is that rather than increasing the luminal B cohort, which other investigators have shown, in this subset, there was an increase in the HER2 enriched cohort. You can also see that there are other cohorts that are enriched, such as the normal-like, and a slight increase in the number of basal-like cancers. What's interesting is if you separate out these groups, and we've done that as well in early stage breast cancer using the 70 gene assay called MammaPrint in I-SPY 2, you can see that the cancers that are hormone receptor positive but non-luminal have endocrine resistance and generally have been associated with a poor outcome in the metastatic setting, which is quite interesting. But if we look at the different shades of blue, there really isn't any difference in the in our recommendations right now. Unlike the beautiful description that Rebecca Dent gave, we don't have such a description for luminal A and luminal B in the metastatic setting. We really treat these tumors the same way. And we'll talk a little bit about how we might be able to stratify them more in the future, although we don't have these abilities now based on other indicators. Now, this is actually cohorts from combined cohorts from Paloma 2 and Paloma 3, the phase 3 trials in the metastatic first line and greater line setting, testing the CDK4/6 inhibitor palbociclib. And I show you these really to say that there has been a suggestion in this and, of course, other studies that there may be a difference in intrinsic subtypes based on the presentation. And I think that we really see this in clinical practice, where we see the more proliferative, rapidly growing, less endocrine sensitive tumors having more visceral disease earlier in the course of their disease course. And what you can see actually is that the luminal A here, bone only, is a greater proportion relatively of the tumor compared to visceral disease, where you see relatively less. And again, these are not all metastatic samples. So it may be that in some ways, where your cancer will metastasize and the behavior of your cancer is predetermined at the time of diagnosis. But it also appears that some tumors may actually shift to be more of from a luminal A to a luminal B uh, type disease as the cancer responds to therapy with more resistance. So under the pressure of therapy, you may actually uncover differential subsets of disease. So let's talk a little bit about where we are in the treatment of luminal metastatic breast cancer. Really, the cornerstone of treatment for luminal breast cancer at the moment is the use of CDK4/6 inhibitors. And I'm just going to briefly show you this data, which we're all very familiar with, and some of the highlights I think that are important. In the first line setting, these phase 3 studies have demonstrated a remarkable improvement in progression-free survival in patients whose cancers had progressed at least a year after their last aromatase inhibitor therapy, or in patients who had de novo metastatic disease. The benefit of CDK4/6 inhibitors in these trials, and shown in a number of elegant presentations, including an update with the Mona Lisa trials at ASCO this year, has been regardless of site of disease. There has been a suggestion from the Monarch trial analyses that there may be a relative improvement in patients who have visceral involvement or luminal B-like disease relative to luminal A disease. But other studies that have followed patients out for a long time have really seen remarkable progression-free survival, even in patients who have bone only or bone and soft tissue metastatic disease, with progression-free survival medians in excess of 3 years, which really has never been seen with any other treatment. In addition, recently we saw data from a unique trial in the metastatic setting, Mona Lisa 7. This trial focused on patients who were premenopausal at the time of their presentation with metastatic disease, used aromatase inhibitors or tamoxifen as the hormone partner, and randomized to receive ribociclib or placebo. All patients had ovarian suppression. And contrary to prior belief, and something I think which has frustrated investigators, is that patients who are pre and perimenopausal somehow aren't going to respond as well, and we should exclude them from the studies. This trial really showed that that should not be the case moving forward, that if you suppress the ovaries, you can see the same degree of benefit. And if you look at the hazard ratios, and this is going to be important in the next year, really of a big importance, the hazard ratios shown in the PFS line here are identical between these trials. However, Mona Lisa 7, which is the latest of all of these trials to start, is the only trial in the first line setting to show a significant benefit in overall survival. Well, there are several reasons why this might be the case. One is the statistical design, which in Mona Lisa 7 included pre-planned interim analyses. And this is really important because you can see differences before you reach the final number of events. Most of the trials actually have overall survival as a secondary endpoint where you must have a certain number of events before you actually even look at overall survival. The second, I think, is probably even more important, which is that the biology of patients who are premenopausal and present with de novo metastatic breast cancer, which was a higher number in the patients treated in Mona Lisa 7 than in the other trial, is a worse biology that is more endocrine resistant. If you look here, 60% of these patients had no prior endocrine treatment, 30% had a disease-free interval of up to or less than 12 months. So this was a group of patients that had more visceral disease, more visceral involvement, and a generally worse outcome, and seemed to have a striking early benefit in terms of treatment. So what this shows you is that there is benefit in patients who have the most indolent hormone receptor positive disease and those that have the most aggressive disease with visceral involvement in the first line metastatic setting. Now, this is the data actually from the overall survival in Mona Lisa 7, and I show you this not because you don't know it already, but because there are two important points. The interim analysis means that you have a overall survival which can be not reached in the treatment population. So the population of patients receiving ribociclib, the experimental arm, the overall survival was not reached at this final analysis. They will, I'm sure, do updated analyses that will give us more information, but this is the protocol specified final analysis. The other thing that this trial showed was that tamoxifen is not a good partner for ribociclib. It's the only CDK4/6 inhibitor that has potential interaction with other medications in prolonging the QTc interval, so could result in risky tachyarrhythmias, although no patient has been reported to have torsade receiving ribociclib. The tamoxifen markedly increased the risk of having a prolonged QT, and it is not recommended that ribociclib be given with tamoxifen. So now the studies are using non-steroidal aromatase inhibitors. But this is really a pretty remarkable event, and the landmark analyses, I think, are quite intriguing. So what about in the later line setting? And I think the most striking thing we learned here, other than the fact that these were the first studies to present because patients have a shorter PFS, even though they were started after the first line studies, and they showed benefit. So this is great. But I think the most important thing we learned from these studies is shown in comparing Paloma-3 control arm to the control arm of the other studies. And what you see here is that if you had a prior chemotherapy and multiple lines of endocrine therapy. So these patients are more heavily pretreated. About a third had prior chemotherapy. You could have had any number of lines of endocrine therapy. The PFS with fulvestrant alone was only 4.6 months median, compared to double that in the patients who had only one line of prior endocrine therapy and no prior chemotherapy. So what does that tell us? Prior therapy generates resistance globally, and that's really important. We've seen it in triple negative breast cancer. The more treatment you get, the less benefit you're going to get from any treatment that you provide a patient. So the order of our treatment, our sequencing, is very, very important as we try and benefit our patients the most from our selected treatments. In fact, when the first data came out with CDK4/6 inhibitors, some investigators, and perhaps even now, argued that because of the expense of these agents, we should only use them in the second or greater line setting. Also, that maybe we should reserve these agents for patients with the worst potential outcome who have visceral disease or a short disease-free interval. But in fact, this data suggests that we should be always putting our best foot forward, much as we do in HER2-positive breast cancer and now in triple-negative disease. MONALEESA-3 also looked at a combined population with first-line as well, and the first-line subsets are similar to the first-line trials with aromatase inhibitors. So it's really fascinating that the hazard ratios, again, here are almost identical across the three trials. What about Bolero-2? Well, it's hard to compare this because patients did not receive CDK4/6 inhibitors. They received the mTOR inhibitor, everolimus. They could have received one line of chemotherapy and multiple lines of endocrine therapy, certainly up to two. And so we are seeing a very short PFS with fulvestrant, with the exemestane here. Presumably this was in part due to acquired ESR1 mutations as well, but the hazard ratios are interestingly just as good as we saw with CDK4/6 inhibitors in this similar setting. And then the precog trial is shown here, again, similar hazard ratio. So clearly when we add targeted agents, we're benefiting our patients. This shows you the overall survival from Paloma-3. In this group of more heavily pretreated patients, the overall survival, although meeting our strict criteria for a p-value of 0.02, 0.04, depending on whether it was stratified or unstratified, did not meet the pre-specified significant threshold by 0.0235. But if you looked at sensitivity to prior endocrine therapy, which was 79% of patients, you see that the hazard ratio is 0.72. And interestingly, this is very similar to the hazard ratio in the other trials, which did show survival benefits and did not allow patients to enroll who had either endocrine insensitive disease or who had received prior chemotherapy or more lines of therapy. This is shown here with the overall survival data from MONALEESA-3 and MONARCH-2. And MONARCH-2 actually had an endpoint, so it wasn't an interim analysis. The reason why MONALEESA-3 still has that not reached is because this included a first-line and second-line population. So the second-line population drove their statistical significance, but they didn't have the final overall survival because, of course, the first-line population is still doing relatively much better. But they still did see a very good hazard ratio, again, in this 0.7 plus a few numbers range, very similar. The endocrine sensitive group, Paloma 3, Monarch 2, and Mona Lisa 3, all very similar hazard ratios. But here you can see the potential benefit we can get by treating patients earlier, and maybe even more in the first line setting, with a 9.4 months overall survival benefit. And here's the landmark analysis for Mona Lisa 3. Now, one thing that I think is going to be really interesting as we start seeing the adjuvant data that I'll mention in just a moment is, are we going to understand who benefits the most? You know, did we see this survival benefit in Monarch 2 and Mona Lisa 3 because it was a second line setting in a group of patients who are progressing and so have generated more resistance? Or is it really the selection of patients in the early stage setting that makes the biggest difference in being able to see an early difference in overall survival, which is my bet, because I think by selecting higher risk patients in the earlier stage setting, we're mimicking the Mona Lisa 7 population, where we can see a benefit in survival earlier by selecting the patients who have less benefit from endocrine therapy alone. So now one question that's come up a lot is whether there's an optimal endocrine partner in combination with CDK4/6 inhibitors. This is data just presented at ASCO from the Parsifal trial that randomized patients to receive fulvestrant or letrozole with palbociclib. And really interesting, the characteristics are listed here, and I'm happy to provide my slides to anyone who's interested in having them afterwards. Of course, you had to have relapsed more than 12 months from end of endocrine therapy or have de novo metastatic disease. So here you can see the PFS intent to treat analysis, identical between the two arms, absolutely no difference, hazard ratio of 1.13, suggesting that, you know, even though patients who received prior endocrine therapy might have a higher rate of ESR1 mutations, that one, it may be lower than we previously thought in patients who relapse at 12 months or greater after their prior exposure to endocrine therapy, and also that adding an effective targeted agent that's well tolerated could overcome resistance generated by ESR1 mutations. So both are very interesting, and we'll see, of course, further analyses of the tumors and blood that were collected in the conduct of this trial as we go forward. Now, one of the things that's been very interesting is trying to understand who might benefit more or less from CDK4/6 inhibitors. I believe that still our best way of assessing who benefits is understanding the biology of their disease and that they have simply hormone receptor positive breast cancer. But a lot of work has been done in trying to understand this. What we do understand is that you generate resistance clearly in one specific way, and this has been shown in a number of trials. In Paloma 3, at the end of therapy, 4.8% of patients had mutations in RB versus 0 in the patients receiving fulvestrant. And I'll show you some different data on that in just a moment. We do understand that RB loss is a critical component in resistance to CDK4/6 inhibitors, because you do need RB in order to respond, in order to have the impact of CDK4/6 inhibitors. Now, RB loss needs to be a mutation that results in loss of function or deletion, because otherwise a simple mutation, so you have to be careful if you decide not to treat a patient based on RB loss, because if it's not the right kind of mutation, you might be predicting incorrectly. But in any case, this is very interesting. And we've seen some additional data on that at ASCO this year that I thought I would highlight. This is from Monarch 3, a paired ctDNA analysis looking at patients receiving abemaciclib versus placebo plus a non-steroidal AI in the first line setting. Really fascinating data looking at patients who maintained lost or acquired different mutations. And it's all color coded, as you can see here. And what's interesting is that RB mutations, again, selected in 6% of the abemaciclib group. So this happens in the first line setting with AIs, and it happens in the second line setting with fulvestrant. So you can acquire an ESR1 mutation under the pressure of treatment, regardless of the endocrine partner. ESR1 mutations, interestingly, were less frequently selected with abemaciclib versus placebo. 17 versus 31% seems a big number. Now, this is obviously an exploratory analysis, so I wouldn't take it as a take-home message, but it is interesting. It goes along with Parsifal that you might be selecting ESR1 alterations less frequently when you have a very effective partner like a CDK4/6 inhibitor. So now this is data actually, and I apologize for the very full slide, but this is from Fabrice Andre, presented at ASCO, looking at a pooled analysis of ctDNA in the Mona Lisa trials. They identified some markers that could be potential biomarkers of response and decreased activity, but unfortunately these are subsets, so you don't know who you left out. And who you left out, who didn't have ctDNA, may be very important. But they did see RB loss in 1.7%. This is the frequency. And what you can see actually, which I think is very nice to see, these are tiny numbers, but relatively the response is much less, in fact, even favoring placebo, although I don't think that's a real difference here in patients who had RB loss versus wild type for RB, where there was the benefit we're used to seeing with this combination. So their summary is, this is interesting. It's the largest pooled biomarker data set, and I think it's important. They have identified some genes that could be predictive biomarkers that should be analyzed in the future, although ERBB2 and AKT have been analyzed as well as BRCA1 and 2 in tumor samples. It may be important as we're moving forward to really focus on ctDNA. There are also potential predictive biomarkers of resistance, CDK and 2A, which is interesting, 2B and 2C, which I think sometimes in the little reports you get might be listed as predictors of sensitivity. ATM, interestingly, causing DNA repair defect. These are, of course, hypothesis generating. You're missing some of the patients. In hormone receptor positive disease, relatively less patients have detectable ctDNA. There are wide confidence intervals, but this should serve as a model for future analysis of patients in terms of ctDNA and hopefully match tumors in the metastatic and early stage setting as we look for how to treat patients best in the early stage setting who might be developing ctDNA as a first herald for risk of recurrence. So also we've known that CDK2, which encodes for cyclin E, has been associated with resistance to CDK4/6 inhibitor. There's in this elegant paper by Nick Turner, who's done a huge amount of work, not only in resistance mechanisms, but also now in ctDNA. You can see that the cyclin E below median versus above median really differentiate a group of patients. And the numbers are not so small, where if you had high levels of cyclin E, you really didn't appear to benefit. There is a CDK2/4/6 inhibitor currently in a phase 1 trial with some issues with cytopenia, where we're exploring different schedules to see how that works, but it clearly has activity. So this is a new direction for the future. And then ESR1 mutations, of course, are all the rage, with a number of different studies reporting ESR1 mutations with huge ranges, as you can see here. In Paloma 3, I think in Bolero 2, we've really set upon that number as being patients who progressed on aromatase inhibitors, that you see about a quarter of the patients having ESR1 mutations, but the numbers may vary significantly. PATA-1 was presented at ASCO this year. It's a really interesting study, and this is just a preliminary result. It's first-line treatment for patients who have hormone receptor-positive metastatic breast cancer, aromatase inhibitor sensitive. And basically what you're doing is you're treating everybody with an AI and palbociclib, large trial, over 1,000 patients. And then if you become positive by cell-free DNA for ESR1 without evidence of clinical progression of disease, you change to fulvestrant versus not to see whether or not patients will benefit. But what they did in this presentation was look at ESR1 mutations in cell-free DNA at baseline 1 month and every 2 months. The baseline prevalence was 3.2%, as you would expect, relatively low in this AI-sensitive group of patients. What they saw was interesting and hasn't been shown before is that if you have a mutation in the first line setting, that it impacts prognosis, even in combination with a CDK4/6 inhibitor, 11 months in 33 patients versus 26.7 months. However, it's important to keep in mind this is 33 patients, and there may be other indicators that have impacted prognosis in this group of patients. So having such small numbers is hard, but we don't see a lot of ESR1 mutations early on. I think much more importantly, again, small numbers, is this idea that if you clear ESR1 mutation in your blood at 1 month, you had a better outcome than if you didn't. Really fascinating. Again, small numbers, but very interesting and hypothesis generating. 7.4 months for not cleared and 24 months for those who cleared. And then you could see this later resurgence of the ESR1 mutation in a fairly large number of patients at the time of analysis. So how this correlates with their change to fulvestrant over time will be fascinating to see, but it is really intriguing data. There's also information on whether we should give chemotherapy or endocrine therapy. I mentioned the data in Paloma 3, and 3 different trials looked at comparing chemotherapy to aromatase inhibitors with a CDK4/6 inhibitor and showed various results, better improvement in a small phase 2 trial in premenopausal women in young Pearl, whereas data that looked relatively similar with a shorter PFS than we're used to seeing in the Pearl phase 3 trial in postmenopausal women with metastatic breast cancer. There are key differences between these trials, and I think that as we see further maturation of the Pearl data and further analyses, I think it will be interesting to look at these differences in visceral disease, whether or not you'd received a prior aromatase inhibitor to better understand these differences. But I think these data really validate the early use of CDK4/6 inhibitors in hormone receptor positive metastatic breast cancer. As you all know, there are a number of trials and up to more than 15,000 women who've been randomized or are being randomized in adjuvant trials. The 2 trials that have reported press releases, our way of getting first information now, include PALLAS and Monarch E. PALLAS included patients who had stage 2 or 3 hormone receptor positive breast cancer. There were no other criteria. 1,000 patients had stage 2A, so T2N0 disease. Monarch E, however, had patients who had much higher risk disease. You either had to have 4 or more positive lymph nodes, or 1 to 3 positive nodes in grade 3 histology, or a tumor of 5 centimeters or greater, or a central Ki-67 or 20% or greater. As you know, both of these trials completed their accrual, and we saw press releases very close together, less than a month. PALLAS was closed for futility in this relatively unselected group of patients, but in the highly selected group of patients with Monarch E, abemaciclib significantly reduced the risk of cancer recurrence in high-risk hormone receptor positive early stage disease. Incredibly important result, and we look forward to seeing that data at an upcoming meeting. And it will be fascinating to compare this. So we'll just finish and talk a little bit about some of our newer areas of targeting mutations in hormone receptor positive disease. We know that PI3 kinase pathway hyperactivation due to PIK3CA mutations contributes significantly to endocrine resistance, and that this is the most frequently altered pathway in hormone receptor positive breast cancer, about 40%, and that this is a negative prognostic factor. Very nice data shown from SAPPHIRE-02 presented this year, published this year, found 28% of patients had PIK3CA mutations. They had a worse response to chemotherapy, shown here. You can see that the response to chemotherapy is in gray. It was much less in patients with PIK3CA mutated disease, and they had a worse overall survival in this group of patients, regardless of the treatment that they received. SOLAR-1, of course, resulted in approval of alpelisib now in many countries in the world, showing almost a doubling in progression-free survival in the PIK3CA mutated cohort of patients who had progressed on a prior aromatase inhibitor receiving fulvestrant and alpelisib versus placebo. But only 6% of these patients had prior exposure to a CDK4/6 inhibitor because of when the CDK4/6 inhibitors were approved. This trial importantly led to approval of the use of cell-free DNA as a mechanism of detecting mutations. However, we know that it's a little bit less sensitive than tumor, but an easy way to test patients for their PIK3CA mutations. And if you had a mutation in plasma, it resulted in the same degree of benefit that we saw in the tumor assessment of PIK3CA mutations. We presented data from BYLieve, cohort A, at ASCO this year. This trial was in response to trying to understand how alpelisib benefited patients whose cancers had progressed on a CDK4/6 inhibitor and aromatase inhibitor. Cohort A was exactly that group. They were treated with fulvestrant and alpelisib and had known PIK3CA mutations that were centrally confirmed. The primary endpoint was met with a number of patients who were alive without disease progression at 6 months of 50.4%, and a median progression-free survival of 7.3 months, comparing favorably to the SOLAR-1 population with prior CDK4/6 inhibitor exposure, as well as to the overall population as well. We also saw improvement in toxicity, which was encouraging. That education improves toxicity management. And then we did a weighted analysis in a cohort of patients from Flatiron that had known CDK4/6 inhibitor treatment and PIK3CA mutations, showing this really remarkable improvement in progression-free survival compared to the real-world population, looking at the BYLieve population with prior CDK4/6 inhibitor therapy. We also just recently published data looking at the time course of adverse events in SOLAR-1, showing that hyperglycemia and rash are very early events with a median time to onset of just 2 weeks, whereas diarrhea can occur over really the entire course of exposure to alpelisib. These are the 3 most common toxicities associated with alpelisib. We also have shown that you can modify toxicity, and similar to the use of the steroid mouthwash for everolimus stomatitis that has essentially eliminated this as a significant toxicity, I believe that the use of non-sedating antihistamine prophylaxis can also eliminate rash as an issue with this particular drug, an alpha-specific PIK3CA in PI3 kinase inhibitor, and probably also from AKT inhibitors, where I have routinely used antihistamines in patients enrolled on clinical trials. You can see here the number of patients with no events dramatically increases with use of prophylactic anti-rash medication versus those, and the number of patients with significant toxicity markedly decreases. We are working on ways of managing the hyperglycemia, which I think is the current main toxicity with alpelisib, and we'll have recommendations published and additional data about who is at risk in the near future. But we know that obesity, all of the risk factors for diabetes are risk factors for this hyperglycemia, a higher hemoglobin A1C at diagnosis. We also know that dose intensity is important, and published this data showing that if you maintained a higher alpelisib dose intensity, you had a better progression-free survival compared to those with a lower dose intensity per day. So where else are we going? Well, AKT inhibitors are fascinating, and you heard the really interesting data that had been updated at ESMO Breast from Rebecca Dent about the AKT inhibitor ipatasertib. Capivasertib is a similar agent, and the FACTION trial, I think, is just fascinating, a randomized phase 2 study of patients who relapsed or progressed on an AI who were randomized to fulvestrant with capivasertib or placebo, showing this dramatic improvement in progression-free survival and a suggestion of an improvement in overall survival as well. There's an ongoing phase 3 Capitello trial looking in this population, as well as an opportunity trial with ipatasertib with palbociclib and fulvestrant, so a triplet approach, which I think will be fascinating. Preclinical data, elegant preclinical data, has shown that the triplet may delay or reduce resistance to CDK4/6 inhibitors. The toxicity, again, diarrhea and rash, similar to what we've seen, but less hyperglycemia. There are new generation SERDs that are being evaluated that may overcome ESR1 mutations. Of course, we're interested in the ability of oral SERDs to overcome resistance and resistance to that we see with, for example, the injectable SERD fulvestrant, and potentially be more potent inhibitors. This is just a summary of early results. There is a phase 3 trial with elacestrant that has shown activity in fulvestrant-resistant disease. And then the SAR drug is also in a registration-based trial. Some of the some of the oral SERDs, as you can see in gray here, have actually fallen off because they had more toxicity or they just didn't have enough efficacy. So this is going to be a fascinating area. I expect we'll see more in the future. There also is a great interest in combining CDK4/6 inhibitors with immunotherapy, but we presented data on enhanced toxicity in the liver and potentially to the lung with the combination of abemaciclib, pembrolizumab, and an aromatase inhibitor, as well as, and then there are other studies that are looking at this. There are triplet therapies looking at, as I mentioned, CDK4/6 inhibitors now and AKT inhibitors, which I think will be intriguing since the other combinations resulted in intolerable toxicity. This shows you a paradigm that I've developed, we can use currently with treatment, but is rapidly changing based on the presence or absence of a PIK3CA mutation and whether or not you have moderate or poor endocrine sensitivity at diagnosis. I think that we could still try using the mTOR inhibitor after a PI3 kinase inhibitor or an AKT inhibitor for that matter. We are seeing some evidence of response in sequence and non-overlapping resistance. There's also studies that are looking at CDK4/6 inhibitors after CDK4/6 inhibitors. One just collection of cases showed that abemaciclib appeared to have some benefit in progression-free survival, just showing a PFS over 7 months after progression on other CDK4/6 inhibitors. 2 randomized trials are currently exploring that area. Thank you very much.
Thank you so much, Hope, for this great review. I think it was we review everything in just a little time, but we have very great idea of everything. We are running out of time, but at least a couple of questions. The question that I think everybody wants to hear, and is that what guides you to choose one CDK4/6 inhibitor over the other in the first line setting? Toxicity profile, premenopausal status. In other words, do you see significant differences regarding efficacy among all the CDK4/6 inhibitors?
You know, we do see some preclinical differences in terms of potency of inhibition of CDK4 and 6. And this may play out in the early stage setting to have a role. We don't know yet. But given the fact that the hazard ratios are so similar across these trials, I don't think that we can really say that we have that information in the metastatic setting, nor that we will in the future unless somebody tackles comparing them all head to head, which I don't think they will. But, you know, I tend to use the trials that have been done in order to select the CDK4/6 inhibitor. So for a premenopausal patient, it seems like it's reasonable to use ribociclib because they have the big trial. For the postmenopausal patient, again, some of it depends on whether or not patients can take a 3-week on, 1-week off schedule versus continuously, and then how much they're bothered by GI side effects. Some of my much older patients don't seem to be able to vary their diet for GI side effects, so that may be a big issue. On the other hand, other patients, the neutropenia is a big issue, and you'd like to have a drug that causes less neutropenia. So I've really just been sequencing the drugs, you know, depending on the patient who comes in, I really select the drug based on the patient and their individual situation.
Okay.
It's
And
good to have choices.
yeah. And there's a very interesting question as well. In patients in first line and with germline mutation, BRCA mutation, and with luminal disease, would you consider first a CDK4/6 inhibitor or a PARP inhibitor?
It's a great question and one that comes up. I think that, you know, the PARP inhibitors have been a huge advance, but they do have toxicities in some of our patients. And I think that, you know, relatively, you know, none of it is a free lunch, right? I mean, you have toxicities with both classes of agents. Because we already have some survival data with the CDK4/6 inhibitors, I think our general approach is to use CDK4/6 inhibitors first and PARP inhibitors second. How this works when we have data from the AKT inhibitors will be interesting, but we want to try and give the PARP inhibitors before we use chemotherapy if we can. In a hormone receptor positive group of patients, we don't have data with combinations with endocrine therapy with the PARP inhibitors yet. So I would give a CDK4/6 inhibitor first, unless a patient in the future has developed progression on an adjuvant CDK4/6 inhibitor.
Okay, sure. And what is your clinical practice with alpelisib in patients that have previously received prior CDK4/6 inhibitor? We know the data from BELIEVE that you recently present, but in real life, you know that EMA have not approved alpelisib in patients previously treated with CDK4/6 inhibitors. So what's your clinical experience with this
We use
situation?
alpelisib in patients in the second line setting who have PIK3CA mutations and of course are eligible based on their disease characteristics. But I don't have any qualms about using it post CDK4/6 inhibitors therapy and progression. In fact, I think that the comparison of real world data to the BELIEVE cohort is really important. We don't want to require huge cost in development of our drugs. We want our patients to be safe and provide effective therapy. But we also want to be able to learn from what we've already done. And as we're doing randomized phase 3 trials, the standard of care is changing and new drugs get approved. And we have to be able to manage that without requiring another 4 years of another randomized phase 3 trial with great expense and expense to our patients as well. So I feel like the real world evidence is an excellent way to really understand the benefit of alpelisib, and hope that the regulatory agencies can come to see that benefit for the benefit of our patients in the future.
Totally agree. Thank you so much again for being here. Thank you because we know that you have to run now to clinic. So thank you so much, and we really appreciate being here. Thank
Thank
you.
you so much for inviting
Thank
me,
you,
and great
Hope.
conference. Excellent. Thank you.
Great talk. Thank you.